Now for our first speaker, speaking on the use of coronary artery calcium score for cardiovascular risk stratification in women is Dr. Jefferson Baer. Dr. Baer grew up in Chapel Hill, North Carolina, and performed his undergraduate work at UNC Chapel Hill before going to UC Berkeley for a master's in public health and epidemiology and biostatistics. He came back to UNC Chapel Hill for medical school before heading to the University of Pennsylvania for his internship and residency. He then completed his cardiology fellowship at the University of Washington in Seattle, where he trained with Dr. Greg Bown and Dr. John Brunzel, focusing on preventive cardiology and lipidology. After coming to Emory in 2008, he began collaborating with Dr. John Puskas and the Emory Cardiothoracic Surgery Center for Clinical Research and participated in Cardiothoracic Surgical Trials Network, the surgical treatment of ischemic regurgitation trial. His interest and experience with mitral regurgitation and valvular heart disease eventually led him to becoming the medical director of the Emory University Hospital Midtown Echocardiography Lab in 2019. And this year, in 2021, he has transitioned to the chief of cardiology at Emory University Hospital at Midtown. He continues to enjoy general cardiology with special interest in preventive cardiology, lipids, calcium scoring, and premature coronary artery disease and valvular heart disease. Dr. Baer, thank you so much for joining us today. And we will now go to your speaker.
Jefferson Baer. I'm one of the preventive cardiologists at Emory Midtown Hospital, and I'm going to talk to you guys today about coronary calcification scoring in cardiovascular risk stratification for women. So I have no disclosures, although I will say that I've always been a skeptic of calcium scoring for many years. So I come at this from, I think, a fairly honest perspective. As it's gained acceptance because of all the data that's accrued, I've really become quite a believer in it. So I want to share my thoughts about it with you guys. So how to stop a heart attack before it happens. This was a Time article, a headline about coronary calcium scoring many years ago. And there's been a long evolution of calcium scoring. And it's kind of come into its own recently and has been incorporated into the guidelines. And so we'll kind of go through some of that progression with you guys today. So the first formal calcium scoring was done in 1990. It really is important to understand that calcium scoring measures plaque burden, not stenosis severity. And we'll talk about why plaque burden is probably better than stenosis severity. Calcium is defined as greater than 130 Hounsfield units and has to be at least 1 millimeter of area. And Agatston score was developed by Arthur Agatston, a cardiologist down in Florida, and Warren Janowitz, who was a radiologist. So the goal of calcium scoring is really to identify high-risk patients that would benefit from preventive therapies, things like aspirin, statin, diet, exercise, probably not so much PCI and CABG, but perhaps. And the other really important thing that kind of gets lost in all of this discussion about calcium scoring is to identify low-risk patients where you can actually de-escalate therapy. And I'll show you some data on why that might be actually the most beneficial part of calcium scoring. So what we typically do when we see a patient is there are all these risk factors out there that patients may or may not have. And there's all kinds of things. There's good genetics, there's bad genetics, there's unknown risk factors, there's all the things we know about like smoking and exercise. And it's really hard to kind of take all this and come up with a risk score in your brain because there's so many things and there are all these unknown factors that we don't even understand. And so the idea behind the calcium scoring is it takes all of this information, the things we know and the things we don't even know, and it funnels it through a calcium score, a CT scan, and gives you a calcium score at the end. And that's why I like it so much, because it's really hard to synthesize all of these things. I mean, what does it mean if you have a high HDL, but everything else is terrible? How does your brain understand what that risk is for that patient? Well, the calcium scoring system kind of takes into account everything and then comes out with one number. And so it's very, very simple and kind of intuitive, and it's quite, or can be quite helpful. So here's a case to start us off. 45-year-old woman comes to the office and asks about aspirin therapy. A lot has been going on with aspirin. We'll talk about this more some later. No real past medical history, does not smoke, but has a pretty strong family history. Father died from an MI at 45 and brother had a PCI at 51. Blood pressure's elevated, but not terrible. And cholesterol is also elevated, but not terrible. So if you ran this person through a Framingham risk scoring system, you'd have a percentage of 2%. But when you look at this patient, you realize, something's not quite right. I mean, this family history is scaring me. These lipids are kind of ugly. I'm going to get a calcium scoring. And so I told her to go ahead and get a calcium score. And this is what it comes out with: a whole bunch of calcium loaded in the LAD territory. So the question is, have we helped this woman? And I think the first thing to do when we're trying to figure out, is this helpful or not, is does calcium predict ASCVD risk? So this was the MESA database, which was the first kind of large longitudinal study looking at this. And they have a large population where they basically got a calcium score and then followed them over many years and looked at their cardiovascular events. And this is what it showed. So basically this on the left-hand side is cumulative incidence of major cardiovascular events. And here is time. And they stratified it by calcium score of 0 in the yellow, 1 to 100 in the red, the purple is 100 to 300, and then the teal is above 300. And what you see here is a really nice stepwise progression. The more calcium you have, the higher the risk of events occurs. Now, that's pretty understandable and is important. But what is, I think, is perhaps even more important is look at the people who had calcium score of 0. The line is essentially flat. And this really gets at what some people call the power of 0 or the power of nothing. Nothing is actually something. If you have a calcium score of 0, your risk of cardiovascular events is extremely low. And even if you have elevated cholesterol or you have some high blood pressure, your risk is extremely low. And that's extremely helpful because, as you know, there's a lot of patients that really hate statins and don't want to be on it. Their LDL is 140. You kind of feel weird about just leaving that cholesterol alone. Well, if they have a calcium score of 0, you can really feel good that you can de-escalate therapy in those patients. So 2 things to get from this specific slide. 1, the higher your calcium score, your higher your risk is. And if you've got a calcium score of 0, that's really good news. Now, what does calcium scoring look like compared to other risk markers? So here's basically relative risk ratios looking at calcium scoring compared to other things like ABI. This is brachial blood flow, carotid IMT, family history, and CRP. If you look here, the calcium scoring is far better than any of the other assessments of risk. Now, the question becomes, is coronary artery calcium scoring better than traditional risk calculators? And here's where it gets into the weeds. And I don't want to spend a lot of time talking about it, but I think it's important to have a short discussion. So you may think it's easy to show whether one study adds additional benefit to others in terms of risk stratification, but it's really not as easy as you might think. One of the ways of looking at this is this idea of net reclassification index. The idea here is if you take calcium scoring and you compare it to Framingham risk and you look at what amount of people the calcium scoring correctly reclassifies either into a higher risk group or a lower risk group compared to Framingham risk alone. And that's considered the net reclassification index. Here's the number. It's not really a percentage, although people talk about it as a percentage. And that supposedly is not completely correct. And those are the weeds that I really don't want to get into. But here, for the purposes of this slide, what's important is to see is that the higher this is, the more correct reclassification you are doing. And what you can see here is compared to ABI or CRP, calcium scoring is far away better than these other tests at correctly reclassifying risk. Now, here's more of a standard way of looking at these kinds of questions. This is ROC curves, and what you have here is sensitivity on the left and specificity on the right. This line right here is basically a coin toss. And if you got a test that comes all the way out here, that's the best. It would have a sensitivity as approaching 100% and specificity approaching 100%. So the important thing to focus on here is the blue line. Hopefully you guys can see that is just Framingham risk alone. And all these other lines that crowd around the blue line are basically Framingham risk plus some additional thing: carotid IMT, C-reactive protein, family history, ABI, what have you. The line that's way out here is basically Framingham risk plus coronary artery calcification. And you can see this is a pretty dramatic change from these other risk evaluators. And I think this is really the best evidence that we have showing that Framingham risk scores, or I'm sorry, coronary calcium scoring does add significant benefit to just Framingham risk alone. So how do traditional risk calculators like Framingham risk perform in women? This was a study that basically took a group of patients, asymptomatic women, and calculated their Framingham risk, and then did calcium scorings on them. And it was very interesting. So if you took all the patients, these asymptomatic women, you took all the patients who had calcium scores greater than 400, very high calcium score. That was about 83 women. And you looked at those 83 women, 64% of those women would have been classified by Framingham risk as being low risk. So that's a lot of patients that you potentially are missing if you just use Framingham risk calculators in women. And these are patients that potentially would have qualified for aspirin therapy, statin therapy, maybe more aggressive blood pressure management. We'll discuss all these issues later. And so that raises the question of, well, how does coronary calcium scoring perform in women compared to men? And so this was another study that looked at long-term prognosis after calcium scoring in low to intermediate risk women and men. And so this is back to that net reclassification index. In men, it was 0.9. And in this study, again, they said this meant a 4% improved detection of low-risk patient and 5% improved detection of high-risk patients. Not sure that's really the correct way of looking at it, but regardless, you get the idea. The NRI was 0.09 for men. And when you looked at it in women, it was actually almost doubled. It was 0.155. And so the point here is that it looks like coronary calcium scoring is actually better at reclassifying risk and improving risk assessment in women than men. This is another study where they looked at men versus women, and they divided them by coronary calcium scoring. And what you see here is this is women on the left-hand side and men on the right. The women who had calcium scores of greater than 400 were had extremely high mortality rates, much, much higher than men. And so I think the take-home point here is that if you're a woman and you have a high calcium score, that's extremely high risk, and you really need to be quite aggressive in terms of managing the risk factors they have and trying to reduce that risk. So we're halfway through the talk. I just want to give you some take-home points. Calcium scoring clearly improves risk assessment compared to traditional risk calculators. Traditional risk calculators tend to underestimate risk in women, and coronary artery calcium scoring actually estimates risk better in women compared to men. So the next question comes up. This is great. We can improve risk assessment. The next question that kind of comes up is, do statins decrease cardiovascular events in patients who have elevated coronary artery calcium? So there's really only been one trial looking at this, and this was a St. Francis trial, which you guys may be aware of. They basically took 1,000 asymptomatic men and women. The average calcium score was around 530. The 25th to 75th percentile was between 150 to 680 in terms of their calcium score. Average age was 59. And they were randomized to atorvastatin 20 milligrams a day or placebo and followed for 4 years. And so here's the graph. So basically the treatment up here is the statin group, and then the control down here is placebo. And this is probability of remaining event-free. So it's better to be higher up than it is to be lower up. And what you can see here is there is indeed a separation of the curve. People who took atorvastatin did better than people who were on placebo. And there was a 31% relative risk reduction for those taking the statin. However, it did not achieve statistical significance. It almost got there, 0.08. However, if you looked at people who only had calcium scores above 400, all of a sudden the relative risk reduction is 42%, and it was statistically significant. So I think that, first of all, this study was clearly underpowered. They only had 1,000 patients. They were low to intermediate risk. If you'd had higher risk patients, or you had followed them for longer, or had more patients in the study, it's my view that you would have had statistical significance in this group here as well. But there certainly is plenty of evidence to suggest that statins do reduce risk in these patients, and there's actually a nice kind of gradation of improved risk reduction the higher the calcium score is. Now, this is another study that looked at statins and coronary calcium. Now, this was not a randomized trial. This was basically people who were followed longitudinally, and they had calcium scores, and then they looked at whether they were on a statin or not, whether it made a difference. And if you had a calcium score of 0, basically you can't even see the difference between the line. There's a blue line in there somewhere, but you can't see it because it's completely superimposable. And the point here is if you have a calcium score of 0, your risk is incredibly low, and there really is no benefit from being on a statin. You do see a separation of the two groups showing benefit of statin if the calcium score is between 1 to 100. And then as you can see, as your calcium score goes up, there's really a significant change in the curves, and you see significant benefit from being on statin therapy. So I think there is plenty of evidence to suggest that statins are beneficial in people who have elevated calcium scoring, and that certainly has been incorporated to the guidelines, as we'll discuss a little bit later. Now, what about aspirin and calcium scoring? Now, this is very interesting. As you all know, there's a lot of talk about aspirin. We've been using it too much in the primary prevention population, and we only need to use it in secondary prevention population. And so there's been a lot of controversy about this. And we were at an article several years ago discussing this kind of an issue. In my mind, what it really brings up is primary versus secondary prevention still relevant today? That's their traditional way of thinking about people without coronary disease or people with coronary disease. And I just want to have us go through a quick thought experiment. So this is a woman that comes to see her physician. She's feeling well. Maybe she's got a little bit borderline elevated hypertension, borderline lipids, but otherwise feeling fine. You talk about exercise and diet and sodium restriction, and you send the patient on their merry way. The next day, she starts having chest pain. She thinks it's reflux. Keeps getting worse. Eventually, she calls 911. They bring her to the emergency room, and they get an EKG, which looks like ST elevation. They cath her, and she's got a very tight 99% blockage here. So the thought experiment is this. If you go back to that day before, she had coronary disease. She wasn't primary prevention. You just didn't know it. And you're kind of waiting for these events to occur, and then all of a sudden you classify them as secondary prevention. And so this way of thinking about those things is very archaic. And what if there was a way, like a calcium score, where you could see right then and there, wow, she's got a lot of calcium. If she needs to be on an aspirin, maybe you could have prevented that STEMI from happening. So I think we need to get away from primary versus secondary prevention. I think it's been very useful for many years, but as technology advances and things change, you have to be willing to adapt. And there was a very interesting study that came out several years ago that looked at the use of coronary artery calcium scoring to guide whether aspirin was helpful for deciding about aspirin therapy. And what they did was, this was the MESA database. They took the patients, and they basically took people who were on aspirin, excluded them, and then people who you didn't know whether they had aspirin, you excluded them. So basically you had 4,000 patients who were not taking aspirin, and they followed them over time. And I presented this slide about 10 times, and I think I've never been able to present it in a clear fashion. So maybe today's my day that I'm going to present it clearly. So what this slide looks at is they grouped people according to their calcium scores of 0, calcium score of 1 to 99, or calcium score greater than 100. And then within that, the blue bars show people who had a Framingham risk of less than 10% and a Framingham risk of greater than 10%. And this is number needed to treat. So you can see here, people who are lower risk, you needed to treat thousands of patients to provide any benefit. People who are higher risk, you needed to treat very few people before you had benefit. And this is the number needed to harm by taking aspirin. Excuse me. So they used the data we have about bleeding risk, and they found that this is the number needed to harm. So the bottom line here is, if you are on this side, the number needed to treat is much higher than the number needed to harm, and there probably is no benefit of being on aspirin, and potentially you're getting harm. However, if you're on this side of the graph, then the number needed to treat is extremely low, and you're not getting anywhere near the number needed to harm. And so what this shows us is that people who have a calcium score of 0, you do not need an aspirin. You're going to be putting yourself at much higher risk of bleeding than preventing a heart attack. Not worth it. Now, if your calcium score is between 1 to 99, then it's a maybe. And in this study, at least, if your Framingham risk was less than 10%, not worth taking an aspirin. If your Framingham risk was higher than 10%, it was worth taking an aspirin. And then the big take-home point, in my view, is that if your calcium score was above 100, it didn't matter what your Framingham risk was, aspirin was going to be beneficial to you. So I think it's really important to remember those two numbers. Calcium score of 0, you really don't need to be on an aspirin. Calcium score above 100, then aspirin probably does provide significant benefit. If you're in here, then it's a maybe. Now, what about hypertension and calcium scoring? This is getting some more traction now. It's kind of the next evolution of calcium scoring. As you guys probably know, these are from the guidelines done a couple of years ago. In stage 1 hypertension, you have to decide, is there ASCVD risk greater than 10%? If it is, you treat with medications. If it's not, then you try non-pharmacological therapy and reassess. And so what I would submit to you is if you have somebody in this range, but they have a calcium score of 0, you might say, hey, you know what, work on diet, exercise, sodium restriction. Let's just keep watching this. On the other hand, if their calcium score is 600, I think you would be quite aggressive in this patient and probably want to consider medical therapy for them. Now, what do the guidelines say about calcium scoring? They weren't in there for many years. However, almost all the major societies now have them. The Europeans say that calcium score assessment with the CT may be considered as a risk modifier in cardiovascular risk assessment in asymptomatic individuals at low or moderate risk. And ACCHA could say consider calcium scoring in borderline to intermediate risk patients. They give a very broad range here, 7.5% to 20%, which is pretty broad, but that's what they recommend. And so I think that this is just kind of a summarization slide to consider calcium scoring in patients at borderline to intermediate risk. Their calcium score is 0, no statin, no aspirin. Calcium scoring between 1 to 99, consider statin, and calcium scoring above 100, initiate statin. Now, there are some caveats to this. There's some disagreement for people with familial hypercholesterolemia, meaning LDL is typically above 200. The recommendation is to just treat that with statin therapy, even if they have a calcium score of 0. There's a lot of reasons for that. I think there's some thought that these people might have soft plaque, and there's no doubt we occasionally see somebody with a calcium score of 0 that does have soft plaque. The other thing is that there's also this idea of lifetime risk. And so, yeah, their calcium score may be 0 now, but they're so high risk lifetime that why don't you start them on a statin therapy early to prevent that calcium from accruing later on. The other group is diabetics. In general, people in the guidelines say to exclude the diabetics from that calcium score 0, no statin group, and smokers are in the same kind of group as well. So what about stress testing and calcium scoring? This is very interesting. The guidelines basically say you do not need to get stress testing if there's elevated coronary calcium scoring, but they kind of leave it up to the discretion of the clinician, which makes sense. But I get a lot of referrals for people coming to see me, oh, don't I need a cath? My calcium score is 600, 700. But I think it's very important to understand a few things about calcium scoring. So calcium scoring is extremely sensitive for obstructive coronary artery disease, 95 to 95%. But the specificity of coronary artery calcium for obstructive coronary disease is very bad. What this means is that calcium scoring is really good for ruling out obstructive CAD, but it's terrible for ruling it in. So this data shows clearly there is no need to stress test somebody who is asymptomatic with an elevated calcium score. I can't tell you how many times people have been cathed with a calcium score of 600, 700, and they've got disease, there's no doubt, but we know that. They may have 20, 30% lesions, but they don't have 99% blockages, this kind of a thing. Now that's for asymptomatic people. If they're symptomatic, then it's a totally different ballgame. And I would go even further than this. There was a study recently that looked at the impact of plaque burden versus stenosis. So they did CTA, looking at actual stenosis, like 90%, 80%, this kind of thing. And they looked at the impact of plaque burden versus stenosis on ischemic events. And what they found is that plaque burden, meaning calcium scoring, not stenosis per se, is the main predictor of cardiovascular events. And so in some ways, getting a cath isn't even telling you any more information if they're asymptomatic. If they're symptomatic, totally different ballgame. But if they're asymptomatic, the calcium scoring is probably giving you more information than a heart catheterization would. So what are the downsides to calcium scoring? As with everything, of course, there are some downsides. One is radiation exposure. We've gotten pretty darn good at this with some of our modern CT scanners. We can get calcium scoring down to less than a millisievert. Just for comparison, a mammogram is about 0.4 millisieverts, and the natural radiation in a year is about 1.5 to 3.5, depending on your altitude. So, you know, I don't like to trivialize radiation, but with the calcium scoring, it really is a very small amount. Discovering benign pulmonary nodules happens all the time. It happened with a patient of mine, pulmonary nodule, bigger than we liked it. He had to have a VATS procedure done, and it was benign. There's no way really around this. Sometimes you can detect some cancers and pick that up. That's a good thing, but this is a downside to it. Although I will say we've gotten pretty good at this now. There's all these criteria with pulmonary nodules, and the radiologists are pretty good at reading this and letting you know this does not need to be biopsied or this does need to be biopsied. So even when you get pulmonary nodules, a lot of times we don't do anything about it. Insurance doesn't cover it, but luckily most places do it for $100, $150 out of pocket. So for most patients, that's relatively affordable. And then just some odds and ends. So interestingly enough, statins do not prevent calcium progression. Calcium continues to progress no matter what we do. So if it's elevated, I don't recommend repeating it in the future because the calcium will go up and it just stresses patients out. So I really discourage it. And yeah, calcium scoring, if you have a calcium score of 0, I typically recommend repeating it in 5 years. For people who are interested, if they're already kind of low risk and doing everything well and they're not interested, they certainly don't have to. But generally speaking, the recommendation is if it's 0 and you want to reassess risk every 5 years, it's reasonable. If your calcium score is elevated, don't repeat it. We discussed this already. And I guess we already discussed this, could use calcium scoring to help in hypertension management. So the take-home point. So I think calcium scoring is safe. It's effective for improving ASCVD risk assessment in everybody, but it seems to be especially helpful in women. Consider getting a calcium score in borderline to intermediate risk patients. Do not get it in low risk patients and do not get it in high risk patients. Not going to be helpful. Traditional risk calculators tend to underestimate risk in women. Calcium scoring performs better in women than men. And don't forget the power of 0. If they have a calcium score of 0, really important, extremely reassuring. You can de-escalate lots of therapies in that situation. And if your calcium score is above 100, really consider aspirin therapy, statin therapy, aggressive blood pressure management, Mediterranean diet, exercise, all of those good things that we know reduce cardiovascular risk. I wanted to thank the conference committee for inviting me to speak, and thank you guys for listening. I hope you have a great day. Take care.
Thank you, Dr. Baer. Very interesting topic. Patients are always asking about calcium scores, and we have quite a few questions here. So let me start to ask you some of them. Are women at a higher risk for elevated calcium scoring based on the fact that they are a woman?
Hi, Gina. Can you hear me?
Yes.
All right.
Welcome.
All right.
Great talk. Thank you.
All right. So yeah, in general, women tend to have less, as women tend to be at lower risk than men typically for cardiovascular disease, giving everything else equal, they tend to have less calcium.
Are there any sex-specific issues, though, about women and calcium? I think is what the question is asking.
I guess I don't understand. I guess I don't understand what the question is. Then I'm sorry. I thought the question was, do women have, in general, do they have more or less calcium compared to men? And I guess the answer to that is that they tend to have less calcium than men. But if they have elevated calcium, that tends to be a worse prognosis than men for the similar level of calcium.
I'm not sure about the question, but I frequently get from our female patients is like taking calcium supplements, which is recommended in all postmenopausal
Ah,
women.
yeah.
Is there something about women having elevated calcium based on maybe more specific to women? Did you have
Yeah.
a thought on that about supplemental calcium?
Yeah, so that's actually really interesting. So there has been evidence that taking supplemental calcium increases coronary calcium. And it's unclear because one of the studies that looked at it suggested that taking calcium supplements decreased risk, but increased the amount of coronary calcium. So it's a little bit, kind of counterintuitive. Um, and so, I mean, my view about that is that if somebody has, really bad osteoporosis and they need calcium, then I would take it. I wouldn't avoid it. But there certainly are a lot of people who are taking piles of calcium supplements that might not need it. And if that, there could theoretically be some harm to that because it does seem to increase coronary calcification. So maybe that answers it better.
Okay, let's go on to the next question. Would placing the patient on aspirin prevent a STEMI with such high blockages of 99% blockage?
Yeah, so I mean, that's a good question. I guess there's two things I'd say about that. Number one, a lot of these blockages we see, they're really 40% blockages that rupture, or they're 40% stenoses that rupture and then all of a sudden turn into 99%. And so even though it's 99% when we cath the patient, the day before it may have been a 50%, but it just ruptured and then you get thrombus, and that's why it's all of a sudden 99%. So I think the answer to that is yes, you could have prevented something in theory.
The next question is, are diabetics and smokers at higher risk for having elevated calcium scores?
Yeah, I mean, just because those are risk factors for coronary disease in general, they do tend to have more calcium, if, everything else being equal, if they don't have those risk factors.
Next question is, what effect does the calcium score have on patients with thyroid or parathyroid disease? And again, I would think they're thinking of calcium in the parathyroid patient.
Yeah, I mean, I think most of the data from this comes from patients who have end-stage renal disease and have abnormalities in the parathyroid, and certainly people with abnormalities in those areas have a lot more calcium. I mean, some of the worst calcifications is in our end-stage renal disease patients. So I think there is definitely some type, a relationship there.
These are tough questions. All right, next is please advise on how to approach an intermediate risk patient. These for me are the toughest to navigate. Otherwise healthy individual, calcium score of 10, no other risk factors, and then would you repeat the calcium in 8 years?
Yeah, so I agree. Those ones that have a little bit of calcium can be tough. There's a couple things we said about that. Number one, people have this idea if they have calcium, oh my gosh, I'm doomed to have a heart attack. And that is not true. Some of the highest calcium scores I've seen, 3,000, 4,000, are in 88-year-old patients, and they're doing just fine. And so I don't want to overstate the fact that having calcium in your arteries is the end all be all. It's not. There are plenty of people who have some calcium and they end up doing just fine. I think the calcium score of 10, I think it depends on the patient. I think if they're young, then that's very different than if they're 70. If they're young, they have a high lifetime risk. If they have elevated cholesterol and they're interested in statin therapy, I think it's completely reasonable to approach it. On the other hand, if they're really anti-statin and they don't want to do that, then I try to focus on things like Mediterranean diet and exercise and all those other things that they can do themselves that they're more comfortable doing. So that's kind of how I approach it. I think when you start getting into the 2, 3, 400s, that's when you really want to start trying to get them on statin therapy, that kind of thing. But I agree, the 1 to 99, I think, is a little bit of a gray area. And there was another part to that question. I may have missed it.
It said, would you repeat the calcium score in 8 years?
Yeah.
But I think we heard you say 5 years was your recommendation.
Yeah. So that's a good question. So if it's 0, typically you repeat it every 5 years. And if it's really high, you typically don't repeat it. However, I will say in these people who are kind of lowish, so the ones that 1 to 99, you could consider repeating it. And if you see a really increase in the trajectory, so if it goes from 10 up to, 300 or 400 in 5 years, then, you might be more aggressive in that patient than somebody who was at 10 and you recheck it and it's 50. So I think that there is some role for repeating it if it's kind of on the low side.
What do you put more emphasis on, the total calcium score or the percentile risk that's age, sex, and ethnicity matched?
Yeah, that's a really good question. I mean, I think, technically you look at the percentiles, but, for me, I always just kind of look at the numbers is honestly the way I usually deal with it. But I agree. I think that technically the percentiles are probably the better way to do it.
Do you have concerns about a patient who has a calcium score of 0, but has heavy calcification in the aorta?
Yeah, so that's a really good question. The aortic calcifications tend to be less predictive of events than coronary calcium is. So I think if they have calcification in the aorta but nothing in the coronaries, I would still treat them as a calcium score of 0, and feel pretty good about that.
How do you explain to a patient when they have a very high calcium score, but their cath is normal? And I'm going to interpret the question of cath is normal being cath is non-obstructive.
Yeah, I mean, I think it goes back to that calcium scoring doesn't predict obstructive disease, but it does predict plaque burden. So I think if they have an elevated calcium score and, when they say cath is normal, I guess, do they mean really like there's no stenosis at all? It's completely normal. Certainly you can have calcium in the walls of the artery and you can have small plaques that cath doesn't really pick up. So I think from my perspective, I think that they still have disease, they still have elevated risk. You just can't really identify it by the heart catheterization.
And what do you say to the patient who had a calcium score of 0, but 5 years later, they have a very high score?
Yeah, I mean, I see a lot of people who progress. I think it's relatively unusual to go from 0 to really high, but that can happen. And I think all is not lost. You still just look at treating all their risk factors and get them on a statin, aspirin, that kind of a thing. So I think that you still have identified the patient before a cardiovascular event occurred. So I think that's okay.
What do you do with your FH patient? If you're going to put them on a statin and aspirin, regardless of the calcium score, do you still get a calcium score in that patient?
Yeah, so those patients I wouldn't. I just would treat them aggressively with statins, and I wouldn't recommend coronary calcium scoring.
And at what age do you think is the best time to get a calcium score?
Yeah, that's a really good question. I remember one time I ordered a calcium score, and like a 38-year-old, and the radiologist called me up and was like scolding me, like, "Why are you getting a calcium score in somebody so young?" And I mean, I think that I think in general we think 40 and above is when you can consider it in the kind of borderline to intermediate risk patients. But certainly there are times where you have people who are a lot younger than that, who have a really strong family history and you're worried about it, that you can consider it at a slightly younger age. But typically the cutoff is around 40 and above. And I would discourage it if in people 75 and older. I don't think it's going to be all that helpful in that group.
All right, I'm not seeing any other questions here. So thank you so much, Dr. Baer. It was very enlightening talk and excellent questions. We appreciate your contributions to our conference today, and thank you for all you do for our patients down at Midtown.
Thank you, guys. Those were great questions. I really appreciate it.